Welcome once again to another edition of the Osteopathic Lyceum podcast. What I'm going to attempt to do this time is sew a few concepts together so that you can fundamentally begin to understand why all of the different systems in osteopathy as a profession, or even many other hands-on manual professions where they have a lot of subdivisions. So you have people who are much more interested in fascia, and people who are much more interested in muscles, people who are much more interested in energetic type work. Going to attempt to use a very, very fundamental concept within the philosophy of science to help understand and explain why all that division is literally just in the mind of the person making the division. It is not necessarily something that is identifiable to an observer. So from the philosophy of science, the term that I want to use is ontology. Ontology in philosophy is the study of reality, what is real, right? You have a spectrum within philosophy, those that will believe that ideas are the most real, and then those who believe that material objects are the most real, right? There are steps in between those things, but that's your general spectrum. Within the philosophy of science, however, ontology is essentially the classification system utilized to compare things. So it is a group of categories in which each thing will be defined in and of itself so that you can compare where they're the same, and then you can identify the specific categories in which they differ. So if you had two shapes, right? So if we have the category, is this a definable shape, right? And you have two separate shapes, and we can say, yes, this is a shape. Object A is a shape, and object B is a shape. Then you can ask, are there 90-degree angles on the shapes? Shape A, there are four 90-degree angles. Shape B, there are no 90-degree angles. There is a continuous line, right? So now we start to see that they're different in that category. We can't quite get to exactly what they are from that. We would need another category, or maybe some subcategories would allow for us to create a categorization of what each shape would be, right? If we say that we have a green square and a green circle, if our first category is color, they're both green. Now, if we ask about the lines, right, are there 90-degree angles? Well, the green square, there's four 90-degree angles. In the green circle, there are no 90-degree angles. So you can see how we can create a classification system that will identify where things are the same if you describe them in and of their own value or of their own right, and where things are different if you describe them in and of their own value. Now, with respect to osteopathy or hands-on practices, what you're going to get is a large amount of division within the professions. Regardless of which hands-on profession you're speaking about, the environment of observation is the same. So if we're building an ontology, we're building a classification system, if we ask for the environment of observation, it is the same. It is the practitioner external to the patient. You are not observing in any direct way any internal processes. You are observing motion and motion characteristics, either in the form of joint movement on the macro level or macro motions, generally speaking. You are also observing yield to pressure in soft tissues. You squish the soft tissue, it squishes the same as the other soft tissues in its area, or it does not. So you can identify difference. But environment of observation is the same. If you're trying to, within osteopathy, figure out what is the same about things. So if you take, say, facilitated positional release, ligamentous articular strain / balanced ligamentous tension, and you compare these things, right? If you say, what's the environment of observation? The environment of observation is practitioner external to patient. If you ask whether or not there is a required assessment, yes, there is a required assessment. So you see they're the same. When you ask about how technical applications are provided, so once you have identified through a hands-on assessment or an assessment external to the patient that is done by movement, either macro movement of joints or micro movement, more so in the form of yield pressure of soft tissue, so you squish the soft tissues. Once you find the problem, the question is, what do you do, right? If you go by the details, FPR, or facilitated positional release, you neutralize the anatomy, you take it to a neutral, and then you add an activating force in the form of compression, distraction, torsion, or shear. In LAS, BLT, it's disengage, exaggerate, and balance, right? So what you're doing, you could argue that the balancing step in FPR is the neutralizing, and then the balancing at the end of LASBLT is where you're kind of getting to some kind of neutral, but the way in which you apply them both, the way that you know that you've done either one through the steps, so FPR, neutralize the anatomy, then add an activating force in the form of compression, distraction, torsion, or shear, versus LASBLT, disengage, exaggerate, and balance. The way that you actually do that, that you know that that occurred, is you're monitoring soft tissues, and the soft tissues in the area that you're attempting to treat, at the end of those steps, it's the same target. The soft tissues should go soft. You should go to ease. So if you stick to the details that are described in either system, they look different. But if you observe them from the outside, so if your category was, how does the practitioner know that they've gotten to the point that they're looking for with respect to application of treatment? And that would have to be described as making the soft tissue soft. So fundamentally, while there are different descriptions of the steps that you take in LAS and BLT, they both have the same end goal in treatment, or say midpoint goal in treatment, to make the soft tissue soft. So once you've made that soft tissue soft, you know that you've achieved what you were looking for through whatever set of steps. So on the macro level, or in the category of how does the practitioner know that they achieved their midpoint goal with treatment, LAS, BLT, which is the same, like that's actually the same. Sorry, it's just LAS/BLT, FPR, it's the same. They're the same. If you look at functional technique, you're making the soft tissue soft, you're taking tension off. If you look at strain counterstrain, you're making the soft tissue soft. So anything that would fall under the auspices of the practitioner knowing that they've done what they wanted to do at the midpoint of treatment is that the soft tissues have gone soft, and they're monitoring for the soft tissues to stay soft, and they might have to make micro adjustments, but the soft tissues need to stay soft. The thing that unites that, then, if you go to another category and you ask about the barrier concept, well, all of those would be indirect barrier. An indirect barrier could be described as making the soft tissue soft. If you look at something like MFR, or myofascial release, at least in the direct sense, if you look at articulation, if you look at, now articulation doesn't necessarily mean HPLA, it just means moving into bind repetitively, or just generally moving one thing in relation to another. So you move them appropriately with relation to one another, might be a better way to say that. If you look at muscle energy, if you look at any of the direct systems, the way that the practitioner knows. So if we go through environment of observation, external to the patient, is there an assessment required? Yes. How do they do that assessment? Well, macro movements of joints, so large movements identifying smaller problems, and then kind of more micro assessments of the soft tissue yield the pressure of soft tissue. You have the same. So LAS/BLT, FPR, functional technique, muscle energy, it doesn't matter which one, they're all the same on these categories, until the point that you get to where you would say, how does the practitioner know that they're doing what they want? Well, in any of the systems like myofascial release or muscle energy, what you're looking for is the addition of tension to the tissue. So the tissue should get tight without the patient saying, ouch. Right? So you should be short of a pain response, whatever that pain response may be it verbal, be it physical, so either auditory or visual, right? So the patient pulls away, the patient makes a noise, things of that nature. That's the direct methodologies, is you're adding tension into bind, or into restriction rather, short of the patient displaying a pain response. So what you then have is a more macro category, or a larger category, whereby the environment of observation is the same. The requirement of an assessment is the same. The midpoint of how the practitioner knows whether or not they're applying treatment as they want is soft tissues going soft, or the soft tissues having tension added to it in the direction of bind or restriction. So now you can see that that's the category where these things become different, is the barrier concept. How are you going to apply this? Now, if you look at something like visceral or cranial, okay, cranial and visceral, if you look at their assessment methods, or if you look at their environment of observation, external to the patient, they may make claims internal to the patient, but it's external to the patient. Is assessment required? Yes, assessment is required. How is assessment done? Well, large movements of joints or yield to pressure of soft tissues. The assessment methodologies, how assessment is done, regardless of the details of what movements are done, on the macro level is the same. How does the practitioner know in those systems that they're doing what they want? Well, they're still paying attention to the response of the tissues, right? So the response of the tissues could be the category. Well, and then how you differentiate is the tissue either goes tight or the tissue goes soft. So you can see that these things, if you use the appropriate categories, end up looking the same. So you're creating an ontology or a classification system to try to understand osteopathic treatment. If you look at what is required for osteopathic treatment, it is the same things ad nauseum. You always require an assessment. As far as how you apply treatment, and this is where you can look back at previous things that I've done, previous things that I've talked about, how you make choices about how you make treatment. The patient involvement, the patient is either active or passive. So you could go and look at all of these systems. So muscle energy is the one where you're most likely to see the active patient, but other ones will have active patients as well. Functional technique will have an active patient, right? So you can start to sort these on varying levels based on the classification systems that you use. So you always need assessment. The patient is either active or passive or both, right? But that's a choice. The tissues or the tissue or the tissues that are targeted. So depending on the system that you're talking about, and this is where I'm essentially being generous to all of these systems and saying they make different claims. So they're all talking about trying to aim at different things. So Cranial is going to claim that it is aiming at connective tissues within the internal portion of the skull and the internal portion of the vertebral column, as well as cerebrospinous fluid. So it is both fluid and soft tissue in very specific places. Right? Visceral is aiming at organs that are not necessarily honestly or clearly identifiable from the external environment of observation, but they will claim that they are aiming at soft tissues. That you can say viscera, but it's soft tissues because viscera are made up of varying histology, lots of smooth muscle, and then other soft tissues. So they're aiming at soft tissues. So they would have to be monitoring soft tissues. So you could say that working through the abdomen, you're monitoring the response of soft tissues in relation to how the practitioner will know if the treatment did what they wanted it to do, or it is at the midpoint doing what they wanted to do. Either the tissue that they think they're aiming at is going to get tighter, and they would palpate that through tension in the soft tissue in the area that they're palpating, or it will go softer, right? So they will make whatever claim they want to make, but they're aiming at soft tissues. You can talk about other systems. So LASBLT, you can talk, they will say that they're aiming at ligaments. So you would then say, well, is a ligament a hard tissue or a soft tissue? You would say soft tissue. Well, they want the soft tissue to go soft, right? So they're aiming at a soft tissue to affect the hard tissue. So you can see how these words start to weave in and out of one another. But if you put them into firm categories, you can start to pick it apart and see where they're all the same and where they're mildly different. So you've got an assessment's required. The patient is either active or passive as far as treatment's concerned. Which tissue or tissues do you claim you're targeting? And then the barrier concept. So the barrier is either indirect, make the soft tissue soft, direct, add tension to the soft tissues without the patient saying ouch, or no barrier choice. So some methodologies that you will see described, they're just repetitive motion. They're not paying attention to the barrier, but you still need to not make the patient say ouch. So you can argue that that's a barrier choice or a lack of choice. If you don't want to make a choice with the barrier, you go indirect. So soft tissue soft, and then you go direct, soft tissue tight without the patient saying ouch. This allows you to understand that all of these systems are fundamentally the same because you have to make the same choices. You have to do essentially the same things. You then end up telling a different story about them because of where your hands are and what you interpret to be related to where your hands are, whatever piece of anatomy. So it's almost as though in osteopathy, the behaviors are relatively stable within any system that you want to talk about. The difference is the story that's told about the work that's done. People can literally do the exact same movement, but if they are a cranial practitioner or a visceral practitioner, or claim to be either, they will do the exact same movement and make a different claim. One might say that they are aiming at the inherent rhythm or the inherent motility of the organs. That's the visceral practitioner. The cranial practitioner will say with the exact same move, I'm aiming at the inherent motility of the nervous system or the cerebrospinous fluid or whatever you want to talk about. The move can literally be the same. So the assessment can be the same. The application of technique can be the same. The story will be different. So what I would say is that the fundamentals of osteopathy are the same regardless of which system you want to talk about. The movements are often exactly the same regardless of which system you want to talk about. The stories are different. So you can see that if we use the fundamental concept from the philosophy of science of an ontological classification system or of ontology in the philosophy of science, if we create one, we can talk about the environment of observation. We can talk about, is an assessment required? Yes, that's everything. How do you do the assessment? Well, the patient moves themselves, you move the patient, either large movements or yield to pressure of soft tissues, right? So those are the ways that you test things. Now, there will be different details depending on the system and depending on the practitioner. Practitioners don't always assess the same thing the same way within themselves. So their pre-test and their post-test for the same thing might be different. That is something that has been observed within osteopathic practice. I would say that's bad practice, but it has been observed, right? But there is an assessment required. When they actually start to apply treatment, the patient is either going to be active or passive. So no matter what you observe, the patient is either going to be active or passive. Then you look at the claims, right? So this is kind of the post hoc thing where everything can be the same, but the claims that the practitioner will make on the tissue or the tissues they were targeting will vary. Right? So they will talk about different things. Something that I can say is if somebody's rhythmic, right? They're rhythmically moving within whatever method they're doing, they can say that the rhythm, the rate, the rhythm, and the repetition are inhibitory because they're appealing to the nervous system. They're trying to reintroduce rhythm to the nervous system. Somebody else can be pumping at the exact same rhythm, and they can say that what they're trying to do is move fluid. They can say that they're trying to pump a joint space to move passive fluids, so increase and decrease pressure within the area to help move venous blood and lymphatic fluid. It's the exact same move, but the claim will be different. So you can have somebody put tension onto a tissue and hold onto it, onto a soft tissue, and they can wait. One person will say that they are inhibiting the nerves in the area. They're waiting for the nervous system to calm down. Another person can say that they're doing MFR. The move is the same, but the tissue or tissues targeted will be claimed as different. So that literally the physical application is exactly the same. The claim is different. The barrier concept is where you will see meaningful choice with respect to responding to the patient in the moment as far as how a treatment is applied. Because if the patient says, ouch, you make the soft tissue soft. If you can go into the resisted or the direction of bind or the direction of resistance and the patient does not say ouch, then you can go direct, right? So you have some choices to make. That's the most meaningful place for choice as far as responding to the patient. The patient active and patient passive is a choice of the practitioner and what they want to deal with, but the barrier concept responds most appropriately to the patient. No matter which system you want to speak about within osteopathy, which new system, which old system, whichever system, it comes or it is well described by the same ontological classification system, which is going to be the environment of observation. It's always the same. It's outside the patient. Assessment, yes, it's required for all of them. You must assess, otherwise you don't know what you're doing. You're shooting in the dark. The how assessments are performed is the same. It's about movement, either joint movement or macro movement or yield to pressure of soft tissues. You've got the patient as either active or passive. That's always the same as far as a binary option, or you could say a three-pronged option, or maybe even a four-pronged option: indirect, direct, indirect followed by direct, so that's three, or no methods with no barrier, but you're still avoiding saying ouch. So you could say it's kind of four, like a four-pronged part of the classification system. So there may be four meaningful descriptions. the tissue or tissues targeted, that's the explanation that does not necessarily match up appropriately with whatever physical activity is physical treatment is provided to the patient. And the barrier concept is this thing where you respond to the patient. There is, as far as I can tell, no more requirement for how you describe osteopathic methodology, as there is no more requirement for how you deal with any situation describing osteopathic methodology. That becomes the omnipresent set of things that are required for osteopathic treatment. So assessment and treatment require those things. Because that's the case, teaching from those omnipresent things, you could call those the deep features, or the things that are always there, regardless of how a movement is performed, regardless of how somebody wants to talk about it or think about it or what details they want to use. Those are the categories that are always there. So if you teach those categories and show many examples within those categories, then the prediction would be that the semantic network, or the network of related meaning that the learner would have, or the practitioner would have, is that they wouldn't need any particular method or remember the steps of any method, because they remember the goals and the choices that they have to make. So as far as the environment of observation, there is no goal, there is no choice. You're outside the patient. As far as assessment's concerned, the requirement of assessment is omnipresent. There is no choice to be made. You must do it. How you do it has some choices to be made, right? But how you actually perform it has a stable feature, and the stable feature is it's movement based. Either it's a large movement, or it is, so joint movement, generally speaking, or it is directly on soft tissues and yields to pressure of soft tissues. Those are your options, and you can organize a set of tests in some way around that concept. So there is a choice to be made for the order and the actual tests that you perform. So there's choices there, and you should teach people, and practitioners should be able to organize an assessment that's consistent and stable, such that they test the same things in the same way. Whatever test they find something with after they apply treatment, they use the same test to retest for change, right? So now you can build in validity and reliability and utility of testing procedures, but you can make assessment better if you recognize how assessment is built and that there are ways to do it. So now you have that category, which is the basis of your framework for how you build assessment, either as a teacher, as a learner, or as a practitioner. We've got the assessment, then we've got the patient activity. The patient activity, that's a choice. You choose that the patient is active first or active second, right? So you choose active methods as your initial way in, because you prefer it for whatever set of reasons, or you choose to do passive methods, and then if the passive methods don't work, you choose the active methods. If you choose the active methods first and the active methods don't work, now you can choose the passive methods. So you have a way to choose between patient active or patient passive that's meaningful to treatment, right? Because it either worked or it didn't work. Then you have the tissue or tissues targeted. That's simply a choice based on your cognitive approach to what you're doing. If you recognize that it's the external environment of observation and you are highly uncertain with respect to specific structures that you're interfacing with, then you'll say, hey, you know what, this is the movement that was the problem, and it seemed as though holding it did something good. So it's very unlikely that it was mediated by anything other than lower sensory information, right? Now, direct, you get higher sensory information because you create some relative tension on the tissue, which should be identified through increased sensory nerve firing as far as stretch sensors are concerned. So you can talk to those things, but you can't say the specific muscle, the specific tendon with a high degree of accuracy, because if you ever look at something like orthopedic testing, it's a really good way to figure out where you should do an image. It's not a good way to be exactly sure that a specific problem is there. Sometimes it's exceptionally obvious, but for the most part, it's a really good way to figure out what you should image, not necessarily exactly what structure is or is not disrupted. It can be really close, but you'll have a problem. Versus within the category of the tissue or tissues targeted, you could make the choice to listen to what people who have gone before you and have made major assumptions, to follow their assumptions and say that you were targeting the muscle spindle, that you were targeting the fascia, that you were like a specific fascia, that you were targeting a specific organ, that you were targeting the vagus nerve, things like that. You can try to tell those stories, but that's a choice. I would say I would prefer that people err on the side of uncertainty and say, hey, you know what, the methodology that we use that seemed to make the change was primarily shortening or softening soft tissue. So my assumption is that we were able to minimize sensory firing for a period of time, and that's what likely made the change, but I can't tell for sure. Some story like that would be very appropriate. Some story like, I treated your vagus nerve and now all of your digestive functions have improved. That's a tougher one. It doesn't mean that it hasn't. It doesn't mean that it has. It's just tougher because of the environment of observation, which is omnipresent and there's no choice. Then the barrier concept is the choice that's responding to the patient. If the patient says, ouch, you make the soft tissue soft. If the patient doesn't say, ouch, you can go direct. You can add tension to the tissue short of the patient saying, ouch. Right? You've got choices to be made there. If you teach from details, if you teach FPR from details, if you teach LASBLT from details, if you teach myofascial release from details, if you teach something like muscle energy from details, there's a lot of details to remember. The students, the learners, the practitioners will all forget them. They will just simply remember the details that they like. There will be gaps in the details. They will make all kinds of mistakes, especially as they go from novice to expert, because novices are better at procedural steps and experts are better at outcomes. So the experts, if you tested them procedurally, probably wouldn't look all that good. But if you teach from the omnipresent framework, the deep feature that's always there regardless of the details, then you have the opportunity to make the practitioner, the learner, a generative and agentic, or someone with agency as far as how they practice. So a generative and agentic practitioner. They can make choices. They know how to make choices. They know how to build things from scratch within the osteopathic framework. But if you teach them these subdivided systems, then you are hindering them because they have to remember all those steps, which is high cognitive load. It is unlikely to work in the long term. They're going to probably turn more towards the specific subdivided system that they have the best feelings towards for whatever set of reasons. And then they will try to say that that's how osteopathy works because that's the best part of osteopathy. And you could make this argument for any hands-on system, but the omnipresent categories will allow for better investigation and better teaching and better learning because they're always there. The environment of observation is always external. An assessment is always required. How you do the assessment always requires the same elements. It requires movement of either larger structures or yield to pressure of soft tissues, right? Those are always the elements that are required. You have a lot of choices to make as to how you do that and what you do and what order you do it in. But the elements are always the same. So if you teach those elements and you teach somebody how to make an order, or that they should make an order, and that they should always be considering whether or not their order is doing what they want it to do, they have lots of choices to make there. Then you can go to patient activity, right? So the patient is either active or passive, right? You can describe all osteopathic methods with either a passive or active patient. The tissue or tissues targeted, again, that's the claim, but that's a claim that is made by the practitioner based on their thinking. But you can describe all osteopathic methodologies with the claims on the tissue or the tissues they're targeting. The barrier concept describes all osteopathic methodologies because something must be done, either making the soft tissue soft or adding tension to the soft tissue short of the pain response from the patient. Those are omnipresent. That means that all osteopathic systems are fundamentally the same in how they're going to be built and how they function at the abstract level, such that any of the subdivision is not required, because if you teach and practice appropriately, you can generate those things. Now, I will say that details are required. So you have to teach details. You can't simply teach in the abstract. You have to show details, but you can have the learner generate details so that the practitioner that they will become will be able to generate details. You can provide them technical feedback on the details that they did generate, why it was good, why it could be better, how you could handle the patient a little bit more smoothly, how you could stand closer to what you are working on versus further away, how you could move in a better range to test the patient, things of that nature. You can give those. You can also show specific methods that seem to work well, or specific holds that seem to give a lot of options for methods to apply to the patient. You have to teach details, but if you only teach details, then people have to remember the details, all of the steps to the move. If you teach from concept, the omnipresent framework that's always there, then you give them more opportunities to learn and generate and then have details that they can build from. That is more in line with how osteopathic practice or hands-on practice generally is going to go, because it's going to be a problem-solving process for each individual who shows up. You can have a really nice rough framework that's going to work for almost everybody, but when it isn't working for that person, you need to know how to generate something unique for that patient, and that comes from that omnipresent set of categories, the choices that either can't be made because they're always there, or that the choices you always have to make. If you teach somebody how to build an assessment and then make them build an assessment that works relatively well for themselves most of the time, to get to that point, they have to learn how to assess everything, how to generate an assessment for everything in all positions. And some positions are bad, some positions are good, but they learn that so that they can then make the choice. So whatever tests they choose to use regularly, they know which tests they are not using. So if they don't find what they're looking for or something with the test they normally use or the set of tests that they normally use, they can pull on another test that they've already created by themselves in the past to look for something. They have a choice to make based on something that they know how to generate. Then as far as treatment methodologies, you teach them how to create a treatment methodology. And then which ones are more useful, which ones are more not. You teach them to experiment with that. And then you're teaching them to be generative and agentic. So if you teach the details, if you teach cranial, if you teach craniosacral, if you teach visceral, if you teach energetic work, if you teach muscle energy as a system, if you teach FPR, it doesn't matter which one, you're asking them to remember a lot of details, when realistically the actual physical application follows a very, very small amount of categories and concepts. So there's very few choices that need to be made. But if you make them good technicians as far as how to interface with the patient by providing them feedback based on what they generate, and they learn how to go through that process, then you're going to create the person who is going to function better in that environment that's usually the same. Patients are very, very similar to one another as far as how they will present. However, they're unique enough that you have to problem solve. The problem solving is better described by what would be called FAR transfer. So the ability to learn something in one environment, learn a skill or a concept in one environment, and display or perform it in a very dissimilar environment. Now, the thing about FAR transfer is that it's not necessarily repetition of an exceptionally specific thing, right? An exceptionally specific movement. It's really the learning of a concept that can be applied with very different details. The concept is the same, but the details are very different in many ways, right? So it would be within what we're talking about here, the concept of assessment. Assessment is either macro identifies micro, large movements identify smaller problems. So generally large joint movements, so big movements, right? Side bending left and side bending right, things like that. Rotating left, rotating right of the neck, right? Within that larger movement, there will be something different. So if I was to display it, it would look like this, nice full motion, and then it would look like that, right? So you can see that the neck goes well to the left, it doesn't go well to the right. So the macro movement has a disruption to it, which means some subcomponent of it is disrupted. So that's how you develop a way to test the neck. Now that can be patient active or patient passive. As far as soft tissues are concerned, you squish them, right? So you either squish directly into them or you pull across them, and you will find an area that yields appropriately and an area that yields inappropriately. That is the fundamental concept that must be learned about assessment. But how to test soft tissues in the neck, may be different than testing soft tissues in the thumb. There can be variation. The details will vary, but the concept is the same. So osteopathic practice or hands-on manual therapy practice is highlighted by concepts that are the same and details that are different. right? If you look at other professions such as massage, tapotement is more or less the same, but how you apply tapotement to particular tissues is going to have different details. The concept is the same, the details are different, right? So if you teach how to identify a concept and create details related to that concept, your learner or your practitioner is going to be better suited to live clinical practice in whatever form they are there. Luckily, with hands-on therapeutic practice, the environment of observation being external, it means that the level of complexity that we can really get to, because it's physical performance, it's performing movements with somebody else's body or in relation to somebody else's body, that reduces the level of complexity quite a bit versus, say, medical practice. Medical practice needs to look at internal markers, right? So they need to look at proxies through blood work of how an organ is functioning. They need way more details than a hands-on manual therapeutic practitioner. So a physician has to have more details than a hands-on therapeutic practitioner. So we're essentially in a lucky environment, or an environment that is positively benefited from how it works in relation to those that it treats. So very broadly, just to sum it up, with all of the repetition that I've done, and the repetition is important, it's done on purpose, but there are omnipresent categories that you can make a choice about, some of them, and others you can't. They're always the same, but it reduces the level of complexity to the categories. Within those categories, there's a lot of complexities. How you actually interface with a person's body has a lot of complexity. It has a lot of technical skill, and you need to be able to teach to that. But it's not about teaching the details. It's about teaching how to develop the details and know that the details are working. And one of the ways you know that the details are working is essentially through the barrier concept. The tissue is either softening as you want it to, or you're adding tension without the patient saying ouch as you want it to, right? So you need to teach to how to do that to get that goal. So the level of complexity for the concepts and the details that are required is not exceptionally high. However, there is complexity because those details need to be refined over time. So what I would say is the framework that I have put forth, the ontological classification, that's why we talked about the philosophy of science, because we need to know what ontology is, has very few elements, very few important choices, lots of details contained within it, especially on the assessment and the barrier concept side. There's lots of technical details in there that do need to be taught, but they're fundamental motor skills as opposed to fundamental thinking skills, because they have obvious motor outcomes. The obvious motor outcome is the patient's tissue either gets softer or it gets tighter, you add tension to it without the patient saying ouch. So you can take something that can seem very complex, because if you teach it from details like many in hands-on professions do, it looks complex, it sounds complex, but that's because you're delivering in a complex way. Whereas if you come back to these omnipresent categories and you teach to optimize for far transfer across time, you're likely to develop a more generative and agentic practitioner, which is what is required in osteopathic practice, especially if you want to be successful with your outcome goal, with positively impacting the patient. Whereas if you teach somebody in a procedural fashion, no matter what you say you teach them, no matter if you say you teach from fundamental concepts, you teach from things that are always there, whatever term you want to use, it doesn't matter if you say that you do that. If what you see as an outcome for those who are taught is that they all do the same steps in the same order, no matter who they are or who they're interfacing with as far as a patient population is concerned, then what you have done is you have taught a set of procedures. Now, this has been done with people in Cranial, with people in Visceral, with people in FPR. They learn techniques. This has been done with people who claim that they teach concepts or from concept, and you see that the outcome is that people take the same steps in the same order. So what I'm saying is that there is actually a relatively straightforward way to describe teaching from these omnipresent concepts. There is a lot of skill and detail that is required, and the ability to identify what the learner or the practitioner is doing well and what they need help with. But you can pin that within these omnipresent categories. So osteopathy, hands-on manual practice of other forms, is not exceptionally complicated as far as the categories. There are some of those categories that have complexity of detail and the ability to respond to the patient, but at least the concepts are stable and omnipresent. So the main point in making this case is that, to be fair, the tissue or tissues targeted category is the one where I would say the majority of my personal problem within most hands-on profession lives, because it's the interpretive step. It's the step of thinking and making claims that are not necessarily warranted by the behavior that's stable between practitioners, regardless of what tissue or tissues they say they're targeting. So visceral is not required, right? Because you can't appropriately identify those visceral structures from the external environment of observation. It doesn't mean you can't do something positive to them. It just means that you can't know that in an honest way, either through assessment or through result. You can know that the soft tissue has responded in some way because you're monitoring the soft tissue, but that just means that you're targeting soft tissue, either direct or indirect, with respect to barrier. The behavior remains the same, the claim will vary. So cranial, visceral, FPR, LASBLT, they're all making particular claims that aren't required. You could come back to a more consistent, stable place and talk about, did you make the soft tissue soft? And then if you did that, did the movement observably change between the test that you did first and the same test when you did it the second time? So I think in what I believe would be a relatively polite and professional way, I basically just told most of the systems within osteopathy to kick rocks, because I really think they should kick rocks and suck salt, because they're doing very inappropriate things. They're just talking about a lot of details, so it's bad teaching practice. And then they're also talking about details that epistemologically, or with respect to a theory of knowledge or a theory of truth, they just can't possibly know, because they can't possibly observe them. But they can observe what's happening to soft tissues. They can observe what's happening to motion. So their claims are going to be pinned to that anyways. So why not talk about that? Why not teach to that? So hopefully some of that was useful. Thank you for listening, and I will talk to you again soon.